And welcome to Quarantine University. Thanks for joining me today. I apologize I posted the lecture late, but plan is being offered every Tuesday and Friday unless I notify you otherwise. I'm following on this theme of diseases specific to body parts in the brain, parts of the brain. And today we're going to talk about the pituitary gland. Since this is a common site of requests in clinical practice, and there are a lot of variations of normal, and so we'll review a lot of these today, and I'll try to give you some pearls that I've discovered in my own practice over the years. So at the completion of this, I want you to be able to recognize the normal anatomy of the sella and some of the common diseases that will involve the pituitary gland. So we'll talk about the normal appearance of the pituitary with aging, talk about specific pituitary masses, cysts, and some disorders of the infundibulum, and we'll try to touch on some suprasellar pathology as well. The reason we're asked to image the pituitary because the patients frequently have endocrine dysfunction, and this can manifest in a variety of ways. In women, amenorrhea, galactorrhea are common indications for imaging. Sometimes in the workup of infertility, we'll image the pituitary. And in patients with suspected Cushing's disease or acromegaly, of course, pituitary is a key site of interest because many of these tumors are secretory, and so these are functional adenomas. Now, some cases you can see non-functional adenomas, and so these are not detectable by endocrine testing, but nevertheless they can cause symptoms as a result of mass effect, usually on the infundibulum, and where you can get stalk effect, which will raise the prolactin level slightly, but certainly not above 100. And optic nerve symptoms are chiasmatic symptoms from compression. So let's talk about the normal pituitary gland. The pituitary gland has an anterior and posterior lobe, and the embryology of the pituitary is quite interesting in the sense that that tissues from the brain move down, and tissues from the skull base and nasopharynx move up and meet in the pituitary gland. So the anterior and posterior portions of the pituitary have different origins. And this gives rise to some of the pathology that we'll see later, specifically Rathke's cysts. The normal pituitary, normal posterior pituitary has T1 shortening. Now, initially, this was thought to be due to fat in the posterior pituitary, but of course, there is no fat in the sella. And so this is a kind of an interesting sidelight. I believe it was a Japanese researcher that first suggested that it was due to intrinsic T1 shortening of the posterior pituitary, and that paper was rejected by the literature, by the journals, because everyone thought it was due to fat. And later was, I think, apology was issued to that researcher because they were exactly right. So this T1 shortening is a marker of the physiology. It's thought to be due to some, secretory granules in the gland, but it does indicate normal pituitary function. So when you see the high signal intensity in the posterior pituitary gland, number one, it's a good sign because it indicates that there is a connection between the hypothalamus and the pituitary gland. And second of all, it tells you that these things are working properly. Let's put it that way. So here we have a normal gland. This is the anterior pituitary gland and the post-pituitary gland. And so, you can understand why people might have thought it was fat early on. It looks just like fat. But of course, if you do chemical fat suppressed imaging, this will still remain bright. And so this is what you expect to see in a normal pituitary. That's assuming that you're doing thin section imaging and good quality imaging and the like. But this is what you expect to see. Now, when you see this appearance, this is a T1 sagittal scan in a patient who has diabetes insipidus. that this is marrow in the dorsum sella. This is not the normal posterior pituitary gland. You see the way it goes below the sella? So this can be mistaken for the posterior pituitary, but this is, of course, different. There's no high signal in the posterior pituitary. You can see the patient has this suprasellar mass, which is impinging here on the region of the hypothalamus, optic chiasm. This is mammillary body here. This proved to be a germinoma. And I'll show you another case later, but germinomas are very frequently associated with diabetes insipidus for reasons I can't really explain, but it can help you sometimes when you're trying to decide if you're looking at a chiasmatic glioma or a germinoma. Look at the posterior pituitary gland, because you may see that, that you've lost the normal T1 shortening there. Here's a different patient. Looks pretty normal on this non-contrast scan, but here you can see that there's the infundibulum. You expect to see some high signal intensity here in the posterior pituitary, which is lacking. The patient has diabetes insipidus. This is the post-contrast imaging, which shows you this chunky enhancement of the infundibulum, and this is a patient with Langerhans cell histiocytosis. You can also see this in sarcoid, this kind of thick enhancement of the infundibulum, and of course tuberculous meningitis sometimes will present in this fashion. But again, what I'm trying to show you here is not so much the underlying pathology, but the fact that the loss of the normal T1 shortening in the posterior pituitary gland is an important finding to recognize. Occasionally, you can see it. I think it has to do with the technique that's being used. So it's not always pathologic, but it should get your attention, and you should look for that in all patients. Now, this is what's called the pituitary of the newborn. And in the newborn, the anterior pituitary is bright as well as the posterior pituitary. So this is not a pathologic finding in a baby. But of course, we don't expect to see this in an adult. When we see it in an adult, like in this patient, where you can see how bright the anterior pituitary looks, in fact, it looks brighter than the posterior pituitary on this T1 weighted scan. And we notice that there's high signal intensity in the globus pallidus. We talked about this, I think, in the last session. This is a patient who was on TPN. And so this is manganese deposition in the pituitary gland, kind of an unusual finding, something to look for, but again, a reminder that there's no blood-brain barrier in the pituitary gland. And so you can see findings in the pituitary that you don't expect to see in the brain itself. In the normal pituitary, you expect to see a concave superior margin to the pituitary gland. And the gland height in the midline is about 13 millimeters, which doesn't sound like much, but when you measure pituitaries, you'd be surprised how they can look abnormal but still be under 13 millimeters. Now, this is a variation of normal. Here's a pubertal woman. And so you can see this upward border of the pituitary, not the usual concave superior border, but a convex upward border. This can be normal, particularly in women around pubertal age. You can also see it in pregnancy. Here's a patient. This is a scan from 5 years previous for probably a different reason, might have been for infertility. But here you can see this is the T1 weighted scan from 5 years ago. This is the T1 scan now. You see the normal posterior pituitary. Look at the height of the gland has changed. So this is sort of an increased activity of the pituitary gland that you're seeing. And so this is not a pathologic finding. So again, if this were a man, then of course it might require further investigation, but in a woman in childbearing ages, you can see this as a normal finding. Now, one variation of this, I've seen this, and you notice this child has some other malformations of the brain, but occasionally you'll see, I've seen it mostly in children with a maldeveloped skull base, and they have a small sella. So the volume of the pituitary gland is normal, but it's sort of crowded into a too shallow sella. And so be aware of this if you see congenital malformations otherwise, or kind of a malformed skull base, that you may be seeing a normal pituitary that's shoved into a too small sella, which can give you, again, this convex upward margin that we don't expect to see in adults. Now, this appearance, you can see this downward displacement of the pituitary gland. You can see it again sort of crowded into the bottom of the sella. The sella looks enlarged in this patient. This is called an empty sella. Now we know it's an empty sella and not an intracellular cyst because the infundibulum is not crowded into the back of the cella. You see the way the cella, the infundibulum is not displaced into the posterior portion of the cella. These are frequently referred in as intracellular cysts, but this is a normal finding in patients, particularly over 50 years of age. You know, things slow down, I have to admit, in someone my age recognizes that, and so the pituitary as well. And so you'll see a smaller pituitary gland as people age. So this is not a pathologic finding. This has been associated with pseudotumor cerebri or intracranial hypertension. But many patients have this who do not have pseudotumor. So again, it's kind of an interesting finding, but may or may not have pathologic findings. I just show you as an aside some really beautiful normal anatomy. This is the lamina terminalis of the third ventricle. Here you see the region of the optic chiasm. Here you see the infundibular recess of the third ventricle. This is the chiasmatic recess. Gives you the zigzag appearance in the floor of the third ventricle. We come back through the hypothalamus into the mammillary body and the inner peduncular cistern. So really lovely anatomy here that you see in this normal patient. Now, another reason you're going to have a small pituitary, this is a child, is here you see a very small pituitary gland, and you notice this high signal intensity here in the region of the tuberous area. This is an ectopic posterior pituitary. So this is the normal sort of secretory granules of the posterior pituitary, which are now sort of piled up where they can't go any farther through the infundibulum. Now, this was occasionally thought to be in the literature to be like traumatic childbirth trauma, that sort of thing. But I think twin studies have showed that this is probably somehow a maldevelopment and something to look for in individuals as this child, or young person with a short stature, with a suggestion of diminished pituitary function from an interruption in the stalk. So this is the ectopic posterior pituitary. So let's talk a little bit about some sellar masses. We'll talk a little bit about Rathke's cyst and craniopharyngiomas in that discussion. When you're looking for a pituitary tumor, so this is the usual scenario, is say a college-age woman with amenorrhea who the prolactins may be slightly elevated, and so they'll send the patient in and you want to see if there's an underlying pituitary tumor. The things to look for are asymmetry of the gland. So you need to do thin section images of the pituitary, usually in the order of 2 to 3 millimeters, I think is ideal. And you want to look for the size of the gland and its signal intensity. So the tumors frequently will have a different signal intensity than the normal gland. Look for a shift in the stalk. Now the stalk is not always midline, so you want to be careful not to oversell that finding, but make sure that it matches the mass effect. So if you see a right-sided pituitary mass and the stalk is displaced to the other side, that makes sense. But if the stalk is displaced toward the mass, well, of course, they sort of cancel each other. So be careful and don't overread these scans. I mean, if you really sort of pore over pituitary imaging, you'll frequently find something that's suspicious. So don't call all these patients, as having suspicious for microadenomas. If you have any question, I think dynamic enhanced imaging or early imaging can be very helpful. So this is a pretty straightforward case, I think. Here's a patient who has clinical evidence of a pituitary tumor with acromegaly. Here you see this asymmetry of the pituitary. So here's the carotid on this side. Here's the carotid on the other side. If you look at the height of the pituitary here, the height of the pituitary here, there's too much tissue on this side. Not sure where. Seem to have turned on something. Annotation. So this is the post-gadolinium scan, and here you see there's actually diminished enhancement on this side and diminished enhancement. This patient actually had 2 pituitary lesions. And so this is what you want to look for, is this diminished enhancement and mass effect. Now, what are some of the findings in acromegaly? The clinical findings could be change in the head size, hats don't fit, can be an enlarged sella. just see what's going on here. So you can see the enlarged sella, and you can see that they often have some joint disease as well. And so the reason for the enlarged sella is that patients with acromegaly, usually the tumors are quite large by the time they're discovered. This is unlike the Cushing's cases where the tumors can be quite small at the time of imaging. So you're kind of looking for different things, and it makes sense because the changes are often recognized late in patients with acromegaly, where the manifestations of Cushing's disease come on quite early. These can be diabetes, change in distribution of fat and that sort of thing. And so these are recognized earlier, and the tumors are frequently smaller. So these microadenomas frequently picked up early in women, not in men, because the manifestations are not as evident. So look for shift of the infundibulum away from the mass and rounded low signal intensity in the gland and diminished enhancement. Now, I find in these cases, I like to look at the laboratory values, if anything's available, to know what it means when the history says elevated prolactin. If the prolactin is slightly elevated, then I think I sort of approach the case differently. If I know that prolactin levels are over 200, I'm pretty sure there's a tumor there somewhere. So slight elevations that can be attributed to medication, stock effect, and be careful because sometimes patients come in with slight elevations of prolactin, which is the indication for imaging. And you'll notice that there'll be something in the gland. These are called incidental omas, and people can find these at autopsy in the gland. So not everything you see in the gland is going to be clinically symptomatic. Dynamic imaging, I think, is helpful. It appears that someone is marking on the screen. I would ask that you turn off whatever you're annotating here. Because there's no blood barrier in the normal pituitary, tumors cannot be identified like you can where you're looking for metastatic disease in the brain. And so you want to be careful not to sort of think about the pituitary in the same way you think about the brain. The reason that you can see the tumors on the enhanced scan is because the tumors tend to enhance later than the normal pituitary. And so what we look for is actually areas of diminished enhancement, as I showed you in that previous case. So in this case, you can see this is dynamic imaging. So the way dynamic imaging is done is you do rapid imaging of the gland while you're administering contrast. So you actually have images that are pre-contrast and then during the filling of the gland with contrast. Initially, you'll see enhancement in the central portion of the gland called the distal tuft, right where the infundibulum inserts into the gland. But then you want to look on the early images, are there areas of diminished enhancement? So these dynamic imaging, even though the overall image quality is not great, you can see it's kind of a grainy image. This has to do with very rapid imaging. So you'll get a frame every few seconds, maybe 4 seconds, and you'll have multiple images. And you want to look at them sort of like a movie loop to see how the gland fills in. It should fill in from the center into the periphery. Now, this is what it looks like. Excuse me one second. Someone is annotating these images and it's distracting. So here you can see this is the later image. So we'll go back to the dynamic imaging and you can see this area of diminished filling. And then if you wait a little bit, the gland and the tumor fill in. So the tumor actually is less evident on the late imaging. So again, be careful about this. And I would say that early imaging and dynamic imaging can show you lesions that are difficult to identify on the routine post-contrast imaging. So during the enhanced scan, frequently you'll see areas of diminished enhancement at the junction of the anterior and the posterior pituitary. These are called pars intermedia cysts. Now you'll have to deal with these lesions because these are sometimes called suspicious for cystic adenoma. Sometimes these are called Rathke's cysts. It's a little, in my opinion, these terms are used a little vaguely, but when I see these very small cysts that have no T1 shortening on the T1 weighted non-contrast scan, I tend to call these pars intermedia cysts. Pars intermedia sort of in between the anterior and posterior pituitary. When they get larger and when they have T1 shortening, at that point I'll call them Rathke's cysts. So how can I distinguish a Rathke's cyst from an adenoma? This is a kind of a typical appearance of a Rathke's cyst. Very bright on the T1 weighted scan. Obviously, this is not the posterior pituitary. This is extremely bright here on the T1 weighted scan. No contrast given. Look at the nasal mucosa. These are frequently dark on the T2 weighted scan. So typical appearance of a pretty large Rathke's cyst. Now, could this be symptomatic? Well, it could be symptomatic in the sense that it may cause some change in the function of the infundibulum. And you can see that that they can vary in size over time. Now here's a supraselllar Rathke's cyst. These are not always in the pituitary itself. They can be in the supraselllar region. But as we look over time, here's 2003, 2005, there's no surgery here. And you can see that the Rathke's cyst has decreased in size. So they can vary over time. I showed you in one of the previous sessions that they can hemorrhage. So just be aware of these lesions are called Rathke's cysts. These are non-malignant, but they can cause symptoms, usually by mass effect alone. Now, this is an important paper, I think, that describes how you can discern a Rathke's cyst from a hemorrhage or from a cystic adenoma. Is you want to look on the T2 weighted scan for an area of a low signal intensity within the Rathke's cyst. Now, some Rathke's cysts are very dark, T2-weighted imaging, and so those Rathke's cysts, I think, are difficult to find this nodule, but if you see it, you can have a pretty strong feeling that you're dealing with a Rathke's cyst. And so look for these intracystic nodules. Take a look at this paper. It was in Journal of Neurosurgery. But the off midline position statistically is more likely to be a cystic adenoma than a Rathke's cyst. So look for the position of the cyst within the sella. So that was a cystic adenoma. Now, here's a patient with diabetes insipidus, 67-year-old, has a history of cancer. You notice that there's a mass that extends into the supraselllar region. This is post-contrast. Look at the nasal mucosa, and you can see the sella is not that enlarged. This proved to be a pituitary metastasis. So again, think about this entity in patients who have a history of cancer. How can you differentiate them from pituitary adenomas? The two things I would recommend in these cases, look at the relationship of the size of the lesion to the size of the sella. Oftentimes there's a prominent supraselllar component larger than the enlargement of the sella. And this is a case where I think you want to go back to CT. Many times the metastatic lesions will cause destruction of the sella rather than the smooth remodeling. So again, as we talked about in the past, you want to use CT and MR at the skull base complementary. Look for bony destruction when you're trying to decide if you're dealing with a metastatic lesion or an intrinsic low-grade pituitary tumor. Now, this is a variation of pathology. This is a drug-induced abnormality of the pituitary. You can see the pituitary appears enlarged in this patient who I believe is about 60. You can also see enhancement and prominent enhancement here of the stalk and region of the tuberous cinereum. So this is this is one of these diagnoses you just have to know this, is that the treatment with IPI in patients with metastatic melanoma is associated with a what's called hypophysitis. So be looking for this in patients who have that history. All right, well, I guess we're back in business. So we want to be thoughtful about invasion that occurs. Thank you very much for bearing with me there. So one of the things that will come up when you're dealing with pituitary tumors is the question about when there's extension into the cavernous sinus, because that will affect the treatment and certainly is considered a contraindication to the idea of complete surgical excision of the tumor. So even though patients can present with the variety of symptoms, including cranial nerve deficit, many times the tumors will extend out into the cavernous sinus region, but not be within the cavernous sinus. So one thing you can look, and this is what I mean about these giant pituitary tumors, that you might be inclined to call it some aggressive grade of pituitary tumor, but this histologically is really just another pituitary adenoma. But you see here, there's complete encasement of the carotid artery. When you have complete encasement of the carotid artery, then you want to, this is the situation you're going to say this patient has involvement of the cavernous sinus. Here you have partial encasement of the carotid artery. So if you divide the carotid up into, sort of 90-degree quarters into 360 degrees, we may have 270 degrees of covering of the carotid here, but this in general you wouldn't say is encasement. This is encasement here. So this patient has bilateral encasement of the carotid artery. So this is an example of cavernous invasion. Now, let's talk a little bit about, here's another one. This is complete encasement, complete encasement. So these patients have cavernous sinus invasion. Now, as we look, here's a patient who has this mass, sellar mass, and here you can see it on the axial scan, again, giant pituitary tumor. But these are all considered low-grade pituitary adenomas. So how can we tell when there is involvement of the cavernous sinus when there's only partial involvement? So this paper, I find this pretty helpful, is you want to look for tentorial enhancement. This is from the paper, but if you look at the tentorial margin here and here, you can see that there's enhancement of the tentorial leaf on this side. So this is an example of cavernous invasion of this tumor, which you can see is only barely covering the carotid on this side. Even though it's bulging this way, you can see this is normal enhancement of the cavernous sinus on this side, so this is not encasement. So again, the rule here is just be careful about calling it. I call it when I have complete encasement of the carotid in this fashion, and not when I have partial encasement as on this side. And again, here's the enhancement of the tentorium on this side, not on this side. Now, one pitfall I want you to make you aware of, and I think you should be thoughtful about, is this idea that other things can look like pituitary tumors, particularly here on an enhanced CT scan. This looks like a pituitary tumor, even with that little snowman look with the waist at the diaphragm sella. This proved to be a giant aneurysm. So be thoughtful. Anytime you have masses in the region of the cella at cavernous sinus, you need to have some sort of imaging that would reassure you that you're not dealing with a vascular lesion. So don't forget about aneurysms. Now, for supraselllar and non-pituitary masses, I'm going to show you a few examples of this. If you don't learn anything else today, I think this is important to be aware of this, because this will come up in your practice from time to time, and you can make a significant contribution to the care of the patient, because for these non-pituitary tumors, the transsphenoidal approach may not be the appropriate surgical approach. So here, if we look at this case, we see this enhancing mass here extends into the cella, but you see beneath the mass, there's a normal pituitary gland. So if I can see a normal pituitary gland, this is unlikely, I mean, highly unlikely, as in probably never going to be an adenoma. This is something else. In this case, this is a meningioma of the tuberculum sella, which is drooping down into the sella. Surgical approach for here would be wrong to come from a transsphenoidal approach because in a sense, the first thing you'll come to is the pituitary gland itself, not the tumor. So again, this is important to recognize this is not a pituitary tumor. That's more subtle. If you look on the sagittal scan, you can see this little bit of tissue sitting under here. It looks different than the tumor. You can see again, a little band of tissue under here looks different than the tumor. This is again, not a pituitary tumor. This is another meningioma. This is probably arising either from the tuberculum sella or the sella itself. But look very carefully at the imaging for the ability to see the pituitary. Here's another one. Normal pituitary gland sort of sitting in the bottom of the sella, separate from the tumor, which is sitting on top of it, right? So these are all non-pituitary tumors. This is a recent case we had. So here we see the pituitary gland sitting beneath the mass. Here's the mass above the pituitary gland, enhancing pituitary gland. Relatively lower enhancement of the mass itself, which showed interestingly restricted diffusion. We suspected this was lymphoma, but this proved to be an infundibulum sarcoma. This was biopsied. So again, you can really benefit the patient and the surgeon if you are fastidious about looking for the presence of a normal pituitary gland when you see an intracellular or supraselllar mass. So again, I want you to, that's your take-home lesson for today, is to look for the pituitary gland. Don't assume that every mass arising in the sella is of pituitary origin. So we'll talk a little bit now about suprasellar tumors, of course, craniopharyngioma. I showed you germinoma, and oftentimes these can be difficult to sort out. Optic nerve glioma, germinomas, Rathke cysts, and so on. So let's look at a few of them and sort of get a feel for them. Here's a suprasellar craniopharyngioma. Oftentimes you'll see these in young patients, but not always young. Here you see this separate pituitary gland, suprasellar mass, which has some enhancement, inhomogeneous, oftentimes see cysts. You might even see some areas of T1 shortening. And of course, in children, these are frequently calcified, but not frequently in adults because they're a little different histology. But this is a craniopharyngioma, kind of an inhomogeneously enhancing suprasellar mass you want to keep at the top of your list. These can be also intracellular, and they can be inside the third ventricle. Just another craniopharyngioma, giving you a feeling for the inhomogeneous enhancement and the presence of cysts within the tumor, of course, again, separate from the pituitary gland in this patient. So this is another craniopharyngioma. Now this one is more troublesome. This is, here you can see the pituitary gland, you see the infundibulum. Now you see this mass. The mass is actually within the anterior portion of the third ventricle. This is another craniopharyngioma. Now here we have a suprasellar mass, right? Enhancing. Notice, first your eyes, I want your eyes first to go to the pituitary. Do I see a posterior pituitary gland? No posterior pituitary gland. If you check the history, talk to the clinicians, find out the patient has diabetes insipidus, you can make the correct diagnosis. In this case, this is a germinoma. So really, there's nothing else about this tumor that allows you to distinguish it from, say, a chiasmatic glioma. So look for the history and look for the presence of the posterior pituitary gland. Now here we have, again, you want to look around, check your history. Here we have a suprasellar mass, sort of follows the brain, doesn't look very bright on the T2 weighted scan. Notice these bright spots in the region of the globus pallidus in this relatively young patient, right? This is a patient with neurofibromatosis type 1 with a optic glioma. Here again, this is a different patient, sort of same disease, and you see this enlargement of the optic chiasm, and you see these other spots in the brain. Of course, if you're fastidious about looking at the history, you might know the patient has NF1. So again, this is a normal appearance or a typical appearance of a optic glioma in a patient with neurofibromatosis type 1. Now here again, this is a giant sella, but at very low attenuation here on the CT scan. Is this a giant empty cella? Well, you're obliged, I think, to figure it out. And so here's a post-contrast image. Here's the CTA. This is a low attenuation thrombus within a giant aneurysm. So again, don't be too comfortable calling all things empty cellas on CT scans when the cella is enlarged and there's low attenuation within. So if you can see the pituitary separate from a tumor, it's unlikely to be an adenoma. I use the laboratory values whenever I'm reading pituitary imaging when they're available. When the clinical history says elevated prolactin, that can mean a lot of things to clinicians. It can mean that they're slightly elevated to being highly elevated, and that changes the prior probability of disease when you're reviewing the imaging. So again, you look at the imaging differently if you know what the prolactin values are. And I find dynamic imaging can be very helpful when you suspect a microadenoma or in patients with suspected Cushing's disease. So again, be thoughtful of these are some things I want you to take away today. And I think that you have kind of a better feel, hopefully have a better feel for the normal appearance of the pituitary gland and an approach to finding disease there. I'm going to try to post this on my YouTube channel later today on Rad Physics Quarantine University, and you can see some previous lectures there if you've missed any along the way and are interested in the topics. Many of the cases, of course, are available on my Instagram site, Rad Physics, which I assume you're using to find your way to this Zoom lecture, but if you haven't looked at it, I encourage you to do so. And I would say at this point, if you have any particular topics you want me to cover, I'm certainly open to suggestions. I'm planning to kind of walk you through the brain sort of regionally. The next one I'm going to do is on the normal variations in the appearance of the pineal gland and appearance of pineal pathology. So again, look to that for next Tuesday. We're going to be talking about pineal pathology.